We just have a few minutes left. Maybe quickly on the glioblastoma opportunity, obviously a very difficult tumor. You've shown some very encouraging data there with your immunotherapeutic. Maybe how should we think about, with pivotal, study in GBM, what that will look like, and kind of the timelines there?
Yeah, I mean, as you said, I think the neuro-oncologists like ourselves are very encouraged with the tumor responses. I mean, when you see a tumor that normally doubles in size in about 4 weeks shrink in a couple cases to 70% reduction sustained for about a year, you just don't see that. So I think based on the strength of that data, we have announced that we will be moving into a randomized controlled trial. Overall survival, likely overall survival rate improvements will be a primary endpoint for that. I think based on the strength of that data, there's certainly going to be the potential for, an accelerated approval, because the opportunities for patients right now are so scarce. Everything in the frontline setting of GBM has improved survival by about 3 months. So, I mean, these patients really need something better. And so I think we're excited to be moving that forward in a trial that will happen this year. In the recurrent setting, we still need to spend more time thinking about what to do there. But there, that could, as we've seen, move even faster. There, you would be looking at tumor response rates, because again, you can measure what's happening to those tumors and then see how that translates to improvements in OS rates as well.
And the data we've seen so far has been, effectively monotherapy with different adjuvants. How should we think about, immunotherapeutic combinations, checkpoint inhibitor, maybe an arm in the next trial, David?
Yeah, no, it's a great question, and you're absolutely right. So we know that PD-1 blockade, as an example, has not worked, and that's based on randomized phase 3 trials in the frontline and recurrent settings. Having said that, if you have something like 1901, which can first really re-stimulate and boost these responses and activate those T cells, the PD-1 therapy should be much, much more effective. And so I think we have guided that looking at both the monotherapy and in combination with something like anti-PD-1 is something that we plan to be exploring. Now, the elephant in the room, of course, is that we have an arm with GSK's AS01 adjuvant. And, broadly speaking, the response rate that we've seen in that cohort is very comparable to what we've seen with our GM-CSF adjuvant. So it's pretty obvious to say that we need to decide pretty quickly, what we're going to do with GSK and that adjuvant in terms of, moving it forward into further clinical development.
Right, absolutely. I think we're at the time here. So David, thank you very much. Jeff, thank you. Thanks everybody for tuning in to the VBI discussion, and hope everyone continues to stay safe. Look forward to seeing you at another session.